So we meet here from Mondays to Fridays for our morning raw by the woman of God, Prophetess Rhoda Anna of Manifestation. So we meet here from Mondays to Fridays for our morning raw by the. I'm really getting some feedbacks. I don't know if it's the same at your end.
Yeah, a little.
Okay, right. So I will get it quickly. Hello, wonderful audience. Can you see me? Can you hear me?
Yes.
Can you hear me? Is everything okay, wonderful people? Can you hear me?
Yes.
Yes. Okay, thank you very much. Sorry for that technical problem. So you are warmly welcome to the CS Show, a proud initiative by the woman of God, Prophetess Rhoda Anna of Manifestation of Holiness. We meet here from Mondays through to Fridays for our midnight raw, and the times are 12 a.m. US time, 4 a.m. Ghana time, 5 a.m. UK time, 6 a.m. Europe time, 7 a.m. Lebanon time, and 1 p.m. Japan time. We also meet for our Zion hour and time with the Word of God, Mondays, Thursdays, and Fridays, respectively. And the times are 12 p.m. US time, 4 p.m. Ghana time, 5 p.m. UK time, 6 p.m. Europe time, 7 p.m. Lebanon time, and 1 a.m. Japan time. And so if you love to do the things of God, you are warmly welcome to join us pray. Today, we are going to discuss something about our health once again. In the previous weeks, this is what we have been doing. Today is going to be amazing. Stay glued, don't turn your set off. You are really going to benefit from today's, CS show. Our guest for today is a postdoctoral research fellow. She works with the Mayo Clinic in Worcester, Minnesota. She's interested in knowing the role of microbiome in ovarian cancer, and especially the role it plays in preterm, and especially in Black women. The topic for discussion today is microbiome and ovarian cancer. My guest is in the person of Dr. Abigail Asangba. If you have any questions, if you have any concerns, cross your legs, bring them on board, and she will definitely do justice to them. Doc, you are looking amazing.
Thank you. So are you.
Thank you so much. How has your day been?
So far, so good.
Good, super. Your people can wait to hear from you. What do you have for us? Let's roll.
Thank you. Thank you, Paulina, and thank you, Rhoda, for organizing this program. I'm excited to be here today to talk to you guys a little bit about ovarian cancer, and if time permits, a little bit about the microbiome as well. And so when Rhoda and I talked, she wanted me to get on this program. I was wondering what I could talk about. And the thing that came to me was ovarian cancer, mostly because it's something that is dear to me. And I think that every woman needs to have some idea of what ovarian cancer is all about, and how to listen to their own bodies and hopefully be able to see changes quickly, react, and get saved. So everyone probably has, at least personally, when I heard about cancer, one of the first cancers that I heard about was breast cancer, which I think is probably the most common that we've all heard about. And then I know years back, my dad's older sister died, and she had died from cervical cancer. And something that I remember quite clearly from back then was the fact that she was an older woman, getting to her 70s back then, I think. And she started bleeding again, just like you would when you have your menses, right? And she thought it was weird, but being older and having that, she thought that she actually hid the symptoms at the beginning. So she didn't try to see a doctor or listen to her body to know that this wasn't quite right. until it was too late when she was diagnosed, and of course she died from cervical cancer. So a lot of the time we miss the opportunity to react quickly to how what our bodies are telling us. So the more you know, the better, obviously. So I think what I'm going to do today is try to create awareness of what ovarian cancer is. It's a really difficult cancer, mostly because it's almost impossible to diagnose at the beginning in early stages. And by the time the patient is diagnosed, is already late. And so that makes it really hard for anything to be done to help the person. So one thing that I want to do real quick is give you an overview of what ovarian cancer looks like. And I will share my screen real quick to show you.
Right.
Okay, actually.
Okay, so wonderful people, as Doctor puts everything together to show us her screen, you are here with us on the CS Show, a proud initiative by Prophetess Rhoda Anna of Manifestation of Holiness. Details of our meeting days will be given as we move on in the course of the program. Doctor, take over.
All right, thank you. So I just wanted to give you a quick overview of what the female reproductive tract looks like. So obviously from the vagina going up all the way to the uterus and to the ovaries. So the ovaries is just the organ of the female reproductive tract that produces egg, which is why the woman ovulates. And that egg drops and then comes through. And of course, if you are sexually active, then you can become pregnant through fertilization. But obviously, if you're not pregnant, then you have to pass that egg through menstrual blood. So this is where the eggs come out from. These are the what we call the ovaries, as you can see. Yeah. So this on the right, on the left here is what the normal ovary looks like. But as you can see on the right is what a cancerous ovary would look like. And okay, that's basically what I wanted to share for now. And
okay, so
can anyone hear that noise? Okay.
I will quickly manage that. Okay. Okay. We are good to go, Doc.
Okay, cool. All right. So what is ovarian cancer? We all know cancer is basically overgrowth of cells, right? In every normal human being, you have cells that combine to make your tissues and then combine to make your organs. So when your cells grow, as a typical of every cell, they should grow to a certain age, divide and die. But when a cell becomes cancerous, it decides not to die. As a typical of every cell, they should grow to a certain age, divide and die. But when a cell becomes cancerous, it decides not to die. As a typical of every cell. It's okay, right, sorry. It looks like I was hearing back a replay of what I was saying from before, but I think it's gone now. Okay, so when the cells decide not to die, it's just like continuous overgrowth. They just keep growing and not dying. So ovarian cancer is a growth of cells that forms from the ovaries, just like I showed before. So the cells will quickly multiply. They could invade and destroy other body tissues. And as you saw, the ovary, every female body is made up of two ovaries, one on the left and one on the right. And they produce eggs every month, basically. So one of the biggest problems with ovarian cancer, and one of the reasons why it's really deadly, is because it goes undetected and it can spread to your pelvis, your belly, and that makes it almost impossible to treat. So just like one quick stat about ovarian cancer, and just for you to know how serious it is. In the US, for instance, ovarian cancer is the second most common gynecological cancer, and it affects about 1 out of 70 women. It is the fifth leading cause of death in cancer-related deaths in women, and worldwide is the eighth most common malignancy among women. And it's high. It actually has highest incidence in developed countries. So there are two main types of ovarian cancer. type 1 and type 2. Type 1 makes up about 30% of all ovarian cancers, and type 2 makes up about 70% of ovarian cancers. So typically type 1 is more slow growing or low grade serous kinds of cancer, and type 2 is more of the aggressive type of ovarian cancer. So as with most cancers, there is not a known cause really to ovarian cancer. So I'm not going to be able to tell you today that if you avoid this, then you're free from ovarian cancer. And only about 20% of all ovarian cancer incidents can be explained by genetic factors, right? So we all know that breast cancer, you would have heard of the BRCA1 or 2 genes. Those are the genes that if you have specific mutations in them, it makes you more susceptible, or it increases your risk of actually getting breast cancer. And this applies also to ovarian cancer. So people who've had breast cancer have family history of breast cancer, which I'll talk about in a little bit. But only about 20% of ovarian cancer cases has anything to do with your genetic makeup or anything to do with someone being in your family having had the disease at some point. So now, like I said, there is no known cause to ovarian cancer. Only about 20% can be tracked or to your family history. So then what are some of the risks of ovarian cancer? What are some of the risk factors? What are some of the things that physicians or oncologists look out for in patients who come to visit them? So the first thing is obviously the history of ovarian cancer in your relative. And especially in a first degree relative, which is someone, your mom or your sister, right? So obviously ovarian cancer being something that affects the ovaries, it's like, I should have probably said this before, but it only happens in women, right? It's only women who have ovaries, right? So if there is a history of ovarian cancer in your family, your immediate family, so your mom or your siblings, your sisters, right? Then that's when you should become obviously more concerned. So a history of ovarian cancer in your family. And like I said before, the BRCA1 and 2 genes are genes that we know that mutations in these genes have been associated also with breast cancer. So if you have a personal or family history of breast cancer, endometrial cancer, or colon cancer, those are also cancers that could potentially increase your risk of getting ovarian cancer later in life. And then the next thing that we can talk about, apart from the family history, so if the family is cleared, so you have to go back and see, did anyone in my immediate family have any of these cancers at all? And if that is the case, then obviously you need to be on the lookout and listen to your body even more. So moving away from family history, then we can look at whether the person has ever given birth. So we call this the nulliparotive, which is basically, have you ever given birth before? So if the person has never had any kids, that increases their risk of getting ovarian cancer. And then apart from never having kids, even if the person did not have kids for a really long time, so you have delayed childbearing, you were older before you started having kids, that also could increase your risk of having ovarian cancer. Another thing is how early you started your menses, which we call menarche, right? So how old were you? I remember people used to be a lot older. People would be like 15, 16 before they start their menses, right? But now a lot of women know, even if you have nieces and little sisters, or even your own kids, there are girls who are like 8 or 9 and they already start their menses, right? Which is really stressful for parents, especially because that literally tells you your daughter could become pregnant, right? If she's sexually active. So early menarche is something also, if you start your menses really early, that also increases your risk. And then finally, also, if you have delayed menopause. So menopause is when you finally stop having menses. So if it's something that goes way longer than it normally should. So those risks or those factors are things that could increase your risk of getting ovarian cancer. Now, what can decrease or the risk of getting ovarian cancer. And all of this will tie into, you can see, as you can see with all the things that I've mentioned, they all have to do with your reproductive history, sort of apart from your family history, whether you've had kids, how old you were when you started having kids, how old you were when you started your menses, and how old you were when you stopped having menses, right? So all of this have one thing in common. So what decreases the risk is also oral contraceptive use or birth control pills, right? And so this is something that is not a hard science, as in like, it's not something that was done in the lab, maybe using mice models or some animal model to show that if you feed these mice with a whole lot of oral contraceptives, they had less risk of developing ovarian cancer. No, this is more of an observation kind of conclusion, where women who have been on the pill longer have been shown to have lower risk of getting ovarian cancer. And so this is not particularly a hard science, like I said, but the question is why? Why would that be the case? So as I mentioned before, most of the risk factors that I discussed earlier had something to, apart from the family history, obviously, had something to do with your reproduction, right? So you can see that if you're taking oral contraceptives, and these pills usually have, they always have hormones, right? Estrogen and progesterone, which are the two main hormones that control your menstrual cycle, right? So all of these pills usually have both or one of them. There is the mini pill that would have the progestin. But anyway, so when you're taking those pills, you have the artificial versions of those hormones. So it's sort of thought that the more you take those pills, obviously most of them stop you from ovulating, right? So you are not ovulating as much from your ovaries. Remember, ovarian cancer has everything to do with the ovaries. That's where your eggs come from, and that's how you ovulate and all of that. And so that's how your menses happen every month. So taking those pills prevents you from ovulating, and you are also not getting exposed to natural occurring estrogen and progesterone, which could potentially add to the risk of ovarian cancer. That's what people think is the reason why the risk is decreased when you are on contraceptives, oral contraceptives.
Okay, Doc, so that said, does that mean that you can only decrease it and not prevent it from happening to you?
Yes. Pretty, like I said before, about 20% of even ovarian cancers that have been linked to the mutations in your BRCA1 and 2 genes, only 20% of all incidents that we can confidently in a way say that we know how it's caused because of that mutation, right? So about 80% no known cause. So this is just more of an association. And so it's like women who have had a lot of active reproductive system, monthly cycling, ovulating, getting estrogen and progesterone, your body is seeing that every month, literally every month. So that's a lot of exposure to those hormones, right? So if there is something that would decrease that exposure, that could potentially decrease your risk, right? So there's really not anything that you can say that I can say to you right now to say that you can do this to prevent that from happening, right? Okay. So now knowing what ovarian cancer is, what might make you more susceptible to getting ovarian cancer, now we can get into what the disease is like, the pathology of ovarian cancer. So
okay, so Doc, before you get in there, let me just interrupt. So having said that you cannot pinpoint to say, don't do this or do that and you will prevent it. Does it mean that if one stops menstruating or ovulating, then that person stands the chance of not getting it?
Well, it reduces your risk, right? It reduces your risk. But remember the risk factors apart from early, like delayed menopause, obviously, like, so if you start your menopause on time, that could decrease your risk, right? But remember also you have the family history. And then you have that part which has to do with your genes, your mutations, mutation in that gene, right? So all of these other ones are more like lifestyle choices, right? When you start having kids, whether you decide to have kids, whether you're able to have kids, when you start having kids, all of those are mainly lifestyle choices, things that you could control. But if there is a mutation in your BRCA1 and 2 genes, that's not something you can control, really. It's something that you're born with, it's part of your family. So even if you are able to control all these things, and even when you start ovulating, you can stop ovulating obviously or try to stop yourself from ovulating as much by taking pills, right? That, like you said, the pills usually stop that. So that can help. But things like stopping, getting into menopause is not something that you control that easily, right? So there's no 0% chance for any woman really to say that I'm not going to get this cancer. I remember you had someone on here who talked about cervical cancer.
Yes,
and you remember about HPV, the human papillomavirus, being the main cause, right? So you could try to avoid stuff like that. But with ovarian cancer, we don't really know that yet, right? So that's the part where I'll talk about the microbiome later. But right now, these are the risk factors, and we can only try to decrease the risk, right? And not completely remove it. Okay. So we move on to pathology. So most cancers, when you talk about most cancers, people talk about the histology of the cancer or the stage of the cancer. I think stage of cancer is what a lot of us are more aware of, and that is really straightforward. Or you can also think about the grade of the cancer. So what we mean when we talk about histology, histology is basically when you take your tissues or cells, you take these tissues and you try to study their structure. So I think someone has their hand up. Becky.
Okay, Mama Becky, would you like to say anything? Do you have any concerns, any questions? You want to put something across?
Yes, ma. I just want to ask doctor, how old would a woman begin to have the menopause?
So menopause there's not a hard science to that. Like I said, a lot of things are changing right now, right? Like even with what is it called? Even with menarche, which is when a lot of women will start having their menses. If you remember back then, I remember I had a cousin who said she started her menses at the age of 15. I started by 11 to 12. One of my nieces started, I think, around 9. So it's even decreasing with time. Menopause is pretty much the same. A lot of our lifestyle choices and stuff like that are affecting that. But typically, it should be around 50, about 50. But there are people who've experienced menopause in their 40s. But I think average would be in your 50s, like early 50s. It would be something that is more typical. Yeah.
Okay. But doctor, I started my menses when I was 18 years.
Okay.
And then my menopause, I would say I stopped my menses when I was 56. Is it normal?
Yeah, like I said, so like with even you having you started your menses at 18, which was more typical of older people, right? Like I said, I have an older auntie who started around 15. I started around 11. It was between 11 and 12. I remember clearly. My little niece, she started around 9. So a lot of things people have associated them to, like maybe our food that we're eating right now, our lifestyle choice. A lot of things are attributed to that. But 56, it's definitely normal, because like an average of 50, early 50 years. Yeah.
All right. Thank you, Doc.
No problem. Great. Okay, great questions. Okay. Now, so histology is basically you looking at the cancer cells or the tissues and trying to look at what they look like. And with that, you can have multiple types of ovarian cancer. So you can have the high grade, the low grade, endometrioid, or clear cell, or mucinous. Not that any of this is that important right now to our talk, but just to let you know, there are multiple subtypes when you look at the histology of the cancer. That's just looking at how the cells look like, how the tissue of the cancer cells look like. Now, the most important one I would say is what we would call the stage of cancer. So the stage of cancer, and especially in the case of ovarian cancer, there are 4 stages. So when you're talking about stage, it's basically you're looking at the size of the tumor, right? The size of the cancer cells, the tumor cells, and how far it has spread in your body. Cancer usually starts from a point and then it spreads. So in case of ovarian cancer, we've already established that it starts from the ovaries. So at stage 1, the cancer is still very small. It is still just limited or located within the ovaries. So I actually have a figure that I can share with you guys to make it easier. Okay, so sharing screen.
Okay, wonderful people. So as Doc prepares to show her screen or share her screen, you are on the CS Show, a proud initiative by Prophetess Rhoda Anna of Manifestation of Holiness. We meet here from Mondays to Fridays for our morning raw, 12 a.m. US time, 4 a.m. Ghana time, 5 a.m. UK time, 6 a.m. Europe time, 7 a.m. Lebanon time, and 1 p.m. Japan time. You can join us. We also meet on Mondays, Thursdays, and Fridays for our Zion hour, as well as time with the Word of God. And this time it is 12 p.m. US time, 4 p.m. Ghana time, 5 p.m. UK time, 6 p.m. Europe time, 7 p.m. Lebanon time, and 1 a.m. Japan time. Doug, please go ahead.
Awesome, thank you. All right, so like I was saying before, there are 4 main stages for ovarian cancer. As you can see, like I showed you before, these are the ovaries that are literally at the end of the fallopian tubes. So when it's at stage 1, it's only found in it could be in only one ovary or both ovaries, right? So it's limited or just located in the ovaries. So that's stage 1. It's still really early. Now, at stage 2, you see that the cancer has spread from the ovaries and has gone to other parts of the pelvis. So you can think about the fallopian tubes and even to the uterus, right? So now it has started spreading. Now in stage 3, it moves away from the pelvis and it gets into the lymph nodes, to your diaphragm, your gut, and even your liver. So it's spreading quickly. And then finally, at stage 4, it gets into your abdomen, it can get into your lungs, and can even get into your spleen, right? So those are the 4 main stages of ovarian cancer, right? So, okay. Okay, I'm gonna stop sharing my screen, okay. Now, so those are the 4 main stages of ovarian cancer. So the most important thing is that you try to catch it before it spreads to other organs. And then finally, we can think about the grade of ovarian cancer. So we talked about the histology, which is how the tissues look. And then the stage is how far, the size of the tumor and how far it has spread to your different parts of your body. So the grade is just how the cells look, the cancerous cells, how they look. So you have grade 1, grade 2, and grade 3. So grade 1, the cells will look like normal cells. The cancer cells, they look like normal cells. They are not growing rapidly as you will see in grade 2, where the cells start looking abnormal and they've started growing faster. And grade 3, they've completely grown. They look very abnormal and they have spread aggressively. So generally, when the cancer is low grade, so say grade 1, it means that it's slow growing. It's at that stage, it's still growing slowly. But when it becomes high grade, then it means that it's growing really fast now. So that's pathology of ovarian cancer. Now, what are the symptoms? We've already talked about how it's almost impossible to know the cause of ovarian cancer, apart from thinking about the family history that could predispose you or those other risk factors that we mentioned. So I guess the question is, what can you be on the lookout for? How can you listen to your body and know what to look out for? And that is what the biggest problem with ovarian cancer, right? Ovarian cancer is very asymptomatic at the beginning. In early stages, you can go without feeling anything at all. And when it gets to late stages, then you start feeling some things. right? So some of these things I'm going to mention, and tell me if you've ever felt any of these things before, right? One of them is bloating. You feel very full quickly after eating. You have indigestion, or you have nausea. Has anyone felt anything like this before?
I have felt nausea before, but I don't know if it can be attributed to that or not.
No, yeah. So basically, these are symptoms that are very non-specific. A lot of women in your menstrual cycle, if you know anything about PMS, menstrual syndrome, you are going to feel bloated just before you have your menses, right? Just maybe a week or two before you actually start bleeding. If you're not pregnant, you're gonna have bloating. You're gonna have nausea. You're gonna have indigestion. These are things that happen on normal occasions or like basically like on a monthly basis for a lot of women. So it's not something that stands out. That is, if you start feeling, you're gonna be like, oh my God, something is wrong. I have to go see a doctor. This is something that you see on a monthly basis, on a cyclical basis, just because of the same hormones that work, estrogen and progesterone. They make you go through these things almost every month. So it's difficult to just get to the hospital and try to get any kind of screening or test done to see whether you have ovarian cancer from the symptoms, right? So at the beginning, like I said, in early stages, it's almost impossible to feel anything. Late stages, you feel these symptoms that are very normal in a way, if you call them normal based on like your cycling. And then later, you're going to start feeling your fatigue, which are cancer-related fatigue, loss of appetite, weight loss. And then we have something we call ascites, which is fluid in the abdomen. So you're going to start feeling like you're pregnant. You're going to feel really full. Your stomach is going to become bigger. So that's ascites. It's just literally accumulation of fluid in your abdomen. And there are some people who also have lump in their abdomen. But those are all things that you feel way, way later when things have already progressed drastically, right? So that is the biggest problem with ovarian cancer, is most of its symptoms, apart from the fact that early stage symptoms are pretty much non-existent, late stage symptoms also are very non-specific. They are not things that people would want to go and get checked up for, because they are things you would most likely feel on regular basis. Okay. Okay, so if we don't have any questions, we move on to diagnosis then. So as it stands right now, there is no screening for ovarian cancer. And if you know anything about cervical cancer, which was someone talked about on this show some weeks ago, you can actually get routinely checked up. You do a pap smear every 3 to 5 years, and the doctors can check for abnormal cells and see and also for the presence of human papillomavirus 16 or 18, which have been known to cause cervical cancer. In the case of ovarian cancer, however, there are no screening tests available. There's nothing you can go to the hospital right now to get checked for that they can look into and say you have potential to have ovarian cancer, right? So that is, unfortunately, I feel like when I was going to give this talk, I was discussing this with someone. I said I felt like I was going to be like the bearer of bad news, and most likely would not be able to have any way to make you feel better. I'm telling you all these things that are pretty scary stuff, but also I don't have a lot of good news on how to prevent it, how to even diagnose it or prevent it. It's just because ovarian cancer is the problem with ovarian cancer. Right. And treatment for ovarian cancer hasn't changed in like 30 years. There's not been a lot of advancement in knowing exactly how it happens, what causes it, how to prevent it, or even how to just simple screen for it. And diagnosis is very invasive. So when it comes to trying to diagnose ovarian cancer, if it's for early cancer, if you're suspected early stages, you can do ultrasonography. But if it's advanced stage, then you can do an MRI or CT scan. But so you can see that all these tests are not something, first of all, CT scan, MRI, very expensive. Even just the ultrasound, transvaginal or endovaginal, they are all really expensive tests that women most likely wouldn't just go to the hospital to do these things just because you feel a little bloated or you have some pelvic pain or nausea, which are things that usually come with your menstrual cycle anyways, right? So that makes it almost impossible to be proactive, to act ahead of time and just, get on top of things. Another way, another thing that people can do is to look for those antigen, is a cancer antigen 125. So this is a tumor marker. It's a protein that they can look for in your body that can show if it's elevated. It's usually between like about 0 to 30. But if it's elevated and much higher than that, then that can be an indication that there is a presence of cancer cells in your body. So it can be elevated in blood of certain cancer patients. So that's one of the tumors or tumor markers that you can test for to see if there are changes or if there's any kind of elevation. And then of course you can do biopsy. And this is most often prescribed for patients that cannot have surgery. They are not surgical candidates. And then of course you can do surgical staging to see what stage the cancer is at this point. So grim, I feel like my talk, like I said already, is really grim because a lot of these things are just hard to do. They are not practical things that you can easily test. Like, first of all, no screening available really. And now also even diagnosis is hard. So, and they are all very invasive things, ways of diagnosing ovarian cancer. So if you've been diagnosed and unfortunately you have the really grim news of being ovarian cancer positive, what are the options available for treatment? So treatment depends largely on the stage of the cancer, right? If it's early stage or if it's late stage. So usually in most cases, just like in a lot of cancers, it's usually either surgery or chemotherapy that you use to treat ovarian cancer. So there are a lot of different surgeries, but the most popular ones are hysterectomy, which is basically the procedure to remove your womb. So you remove the whole womb. It means that it's already spread to those other organs. So you remove the uterus completely. Or you can do a bilateral salpingo oophorectomy, which is basically the removal of your ovaries and your fallopian tubes. You can see how those can be devastating for a woman who hasn't had kids yet. If you're taking out your uterus or taking out your ovaries and your fallopian tubes, then that pretty much does it for you when it comes to naturally having your own biological kids. So those are the main ways of treatment. And of course, you can also have cytoreductive surgery, which is basically trying to remove as much of the cancer cells as possible from the abdominal cavity of the patients, if it has spread all the way to those places. And just like I showed you in the figure before, when it gets to stage 4, then it means that the cancer has pretty much spread all the way to your abdomen and a lot of even to your liver and your spleen. And then of course, after all of those surgeries, you can have post-operative chemotherapy. So these are basic or standard treatment options for ovarian cancer. Okay.
Right. So, and then I would want to pose, I have 2 questions I would want to you to address for me. First of all, we know of fibroids. For the, for previous weeks, we have been treating something about the reproductive system, fibroids, endometriosis, and now ovarian cancer. What are the differences between these 3?
Good question. Okay, so I should have said those before. I am a scientist. I'm not an oncologist, and I'm not an OBGYN either. So I'm probably not the best person to talk about these different cancers. I study ovarian cancer because I'm interested in how to get at ovarian cancer, which I'll talk about later. I haven't actually started talking about my part in ovarian cancer treatment. But okay, so I know fibroids are not, they are growth in the uterus, but they are actually not cancerous. They are benign. So I think the person who talked about cervical cancer, if I remember correctly, talked about how tumors can either be benign or cancerous, right? So you can have a tumor that, right? So if it's benign, so fibroids are benign. They are benign growth in the uterus, and they affect also fertility of women, and they cause painful menses and all of that, and a lot of bleeding in in women. So it's not cancer. It's just a tumor, but it's benign. And usually it goes away the older the woman gets and gets to menopause. It naturally will go away. Sometimes they grow large and they interfere with natural happenings in the reproductive tract of the woman, and then they have to be removed, surgically removed, but they are not cancerous cells. So that's fibroids. And the other one was endometriosis. Right. Endometriosis is also a growth. So it's usually also a growth, but when you look in the, I could probably try to look up a picture to show you guys. When you look up the growth that is supposed to be in the the lining of the cervix, the tissues that line the cervix, right? Sometimes you can see them on the outside. That is what usually endometriosis comes about, right? And so the tissues can be found either on the ovaries or the fallopian tubes on the intestines, but it's weird. They should be within the uterus. They should line the lining of the uterus. But weirdly, sometimes they go outside of the uterus. They can get on the ovaries, they can get on the fallopian tubes, and sometimes the intestines. And that also causes a lot of pain for most women. And that is also not cancerous, right? Even though it's able to spread. So that's actually pretty interesting. I remember my boss at work and I had this discussion because she was like, she doesn't understand why endometriosis is actually not a cancer, because one of the main definitions of cancer is that it has to be metastatic, basically spreading, right? And endometriosis, those tissues, they actually do grow and they spread to other parts of the reproductive tract, but it's not considered a cancer. The women bleed a lot, have really painful menses, and it's insane. So that's the main difference between the two. But obviously, ovarian cancer, it starts in the ovaries, and it's obviously cancer, and it spreads to other organs. So that hopefully that helps. But like I said, right? Yeah. Okay, you had a second question.
Yeah, so I don't, probably you would get to that or you may not, but let me put it across anyway. So, I know you are interested in, this microbiome and, and the role it plays in preterm, what would you tell us about that actually?
Okay, that would probably be something that I would want to talk about in a whole different conversation. That's a huge part of something that I'm interested in, right? So preterm birth is basically what we call in Ghana prematurity, right? Babies are born before 37 weeks, or the woman is 37 weeks of gestation. And so like everything else, we are still trying to understand why. Most of them, I think like almost 40%, or I think, yeah, almost 40% of preterm births are spontaneous. It really is not caused by anything. The woman just goes into labor before she's due. There are some that are due to preeclampsia. And if eclampsia, where women have high blood pressure and some other things, I think there are three main things that come with preeclampsia. So that also can be something that happens. And then there's also the preterm premature rupture of the membrane, which is PPROM, and that also induces preterm labor in some women. So like I said, there are a lot of things that can contribute to this. Obviously, your health whilst you're pregnant, your diet, your practices, your lifestyle choices, and some of them, like I said, are also spontaneous, right? So we don't quite know exactly what There could be a lot of reasons. So my role in that, or my interest in that, is to try to understand how the microbiome, in this case, the vaginal microbiome, which I'll talk about in a little bit, so I'll explain later what the microbiome is if it's confusing to you, the role of that in causing preterm birth. Right. So like I said, it has to be a talk that is of completely, it's a whole different talk, but we know the vaginal microbiome of women from different races are very different. Most white women or Caucasians have vaginal microbiome that is dominated by lactobacillus species, is what we call them. And these microbes are known to be protective. They provide all the protection during pregnancy, and they provide the lactic acid producing and all of the good things that you want your microbiome, your vaginal microbiome to have. But in other women, especially Black women, we don't have as much lactobacillus species dominance as white women. Does that mean that our vaginal microbiome is diseased? Probably not, but it could also mean that we are more predisposed to infections. So my interest in that is try to understand whether the differences in your microbiome, the microbes that make up your vaginal community flora, does that in any way make you more susceptible to having a baby before you actually are due to have the baby? So that's preterm birth and the microbiome.
All right, thank you very much.
No problem. Okay. All right, so we talked about how ovarian cancer can be diagnosed, the treatment options that are available. And so now if you get treated, what is how do people usually respond to treatment, which is what we call prognosis, right? So if you get sick and someone asks what's your prognosis, basically what is the forecast of how you're going to be able to respond to treatment, right? So here's the 5-year survival rates with treatments. So when you are diagnosed at stage 1, which is really early, then you have about 85 to 95% chance of surviving. That's a 5-year survival rate. That's about almost 100%, 85 to 95%, which is great, which is why it is important that you are able to get diagnosed as early as possible. By the time it gets to stage 2, your percentage has decreased to 70 to 78%. Stage 3, 40 to 60% survival. And by stage 4, barely 20%. So you see how drastically your survival rates or survival chances just go down the older or the more advanced the cancer is. So if anything you remember for today, it has to be that listen to your body. If there is anything that feels weird, you need to get out there and get all the tests that can be done for early diagnosis, because that is the only way for you to be able to come out better when it comes to ovarian cancer. Because the longer you wait, the more drastically your chances of survival reduces. So if the grade is higher, obviously we talked about it already, means that it's more aggressive. And also, by the time it's at stage 4 or 3 or 4, there's about 70% chance that the cancer will come back. Even after chemotherapy, after all those surgeries and all of that, there's about 70% chance of recurrence. So as you can see, prognosis is not great either. All due to the fact that it's incredibly hard to diagnose ovarian cancer early. And once you're not able to diagnose it early, then it's almost impossible for you to treat it. Okay. So as I mentioned before, there are no screening tests that are readily available for women to go to the hospital, like pap smear, and to get done to say that, oh, you're okay or you are not. So what can you do to be proactive? We talked about the fact that if there's history in your family, if you have family history of ovarian cancer or endometrial cancer or colorectal cancer, or of course breast cancer, which is with the mutations in the BRCA1 and 2 genes, then you know that you have an increased risk to get ovarian cancer. So that should put you on alert. If you start feeling weird, you start feeling things, then you have to get checked up. So if you have any of these predisposing factors, and then also if you have, like we said, all these different cancers in your family, or immediate family, or even someone, your cousins or your aunties and all that. So that's pretty much all you can do, really, is just listen. If you have family history, and if you have all these other cancers before in close relatives or yourself, then you need to get checked up when things start going bad. So that's ovarian cancer. And I have been, there is something that I want to read to you guys quickly. There is a woman who is a professor in a university in Canada who has been, she's 44 years old. She has been diagnosed with ovarian cancer, and she has been sharing her journey with ovarian cancer on Twitter, and it's incredible. I work with ovarian cancer patients. I have samples from them, and sometimes I know that when I look at their follow-up, I know that some of them have passed away, and it's heartbreaking that it's almost impossible to do anything about this. But this woman, she's called Dr. Nadia Chowdhury. She's been living with ovarian cancer, at least got the diagnosed in 2020. And she's right now in palliative care because, and basically almost, she's almost dying right now. She has a 5-year-old kid that she's made, she had to tell the kid and her husband, and she's been very open about her journey throughout and how things are going. So she basically shared her story about how she got diagnosed, and I want to share it with you just so you can have an idea of how a patient felt, things that she started feeling and how she went through it. So she said, in January 2020, I started feeling unwell. I was tired, had vague abdominal pain, severe lower back pain, and mild increase in frequency to urinate. I was treated with antibiotics for a UTI, and UTI is uterine tract infection, even though I did not have any classic UTI symptoms. I also got an endovaginal ultrasound that showed free fluid in the abdomen. Remember, we talked about ascites, which is the accumulation of fluid in the abdomen, and the possibility of a ruptured left ovarian cyst. The recommendation was to follow up in 3 months. Antibiotics plus laxative seemed to treat my ailments, but then by mid-February, all symptoms returned. My doctor prescribed a different course of antibiotics, although again, in the absence of the classic UTI symptoms. Things seemed to improve a bit. Come March, the pandemic struck. By now, my abdomen was bloated, and I was in moderate pain. My bowel movements had changed too, so I kept taking stool softness. I couldn't see my doctor because of the pandemic. I was incredibly tired, but I chalked it up to the pandemic. By April, I was on a 3rd course of antibiotics. My doctor still suspected an ailment related to my urinary tract. I was tired, but thought it was the antibiotics. In May, I had a 2nd endovaginal ultrasound. This one showed that my ovaries were enlarged and had moved towards the middle of my abdomen. There was a lot of ascites in my abdomen too. The radiologist suggested endometriosis. I showed my scan report to my uncle, who is a gynecologist. He said I should get a blood test to check my cancer antigen 125, which we mentioned earlier, also 19 and CEA. These are cancer markers. He wanted to rule them out before pursuing endometriosis as an option. My CA 125 came back at 925. The normal level is 0 to 35. So that already is not good news. That night, I got connected with Dr. Lucy. She's a top gyna in Montreal. The next day, I had endovaginal ultrasound by one of the specialists, followed by a CT scan and blood work. 4 days later, I met her in a clinic. She said 24 out of 25 doctors in the tumor board said I had cancer. She was holding out for endometriosis. 2 weeks later, I had a laparotomy. They cut me open from my sternum to pubic bone. Indeed, I had cancer. They removed all the visible disease in a 4-hour surgery. It happened in June 10, 2020, about 6 months after I first started feeling bad. 4 weeks later, I began chemotherapy. Standard of care for ovarian cancer has not changed in 30 years. Over 18 weeks, I took carboplatin and some ovarian cancer drugs. It was 6 cycles of chemo, once every 3 weeks. My CA-125 dropped, good sign. I was also enrolled in a clinical trial that began on cycle 2 of chemotherapy. I was getting either placebo or immunotherapy before each chemo. Once the chemo ended, I started getting niraparib as part of the trial, in addition to the placebo or immunotherapy every 6 weeks. And those drugs depleted my hemoglobin, but I was fairly functional. Then in mid-December, my CA-125 started to creep up again. Remember, that is the antigen, the cancer marker.
Yeah.
Not a good sign. It crept up slowly, but because this started happening within 6 months of the end of the chemo, it meant that my cancer had a label. It was platinum resistant. It had learned to evade the platinum-based therapy. So we talked about chemotherapy, and most chemotherapies are platinum-based. And so her cancer basically now has become resistant to the treatment. I remained on the clinical trial until March, where I developed a bowel obstruction. This disqualified me from the trial. I began, so she was put on a different drug. Between March and now, I have more bowel obstruction. So basically, you see what I was talking about. She had these symptoms that were not huge, but you realize that at the end, all the tests that she even had to get done were very invasive, very expensive tests, not something you can easily just walk to a hospital to get done. And all she started feeling was pelvic pain, bloating, nausea. These are everyday things for a lot of women. I have nausea like literally every day. And so it's hard to be able to tell, but the most important thing is to be able to actually know what is happening with your body and how to react quickly. So that is the grim news or talk on ovarian cancer. Probably at this point have scared everybody to death. And that's how I feel every time I get into my lab and my research and I think about ovarian cancer. And I keep asking myself, what is the probability of not getting cancer? As a woman, from your vagina, your uterus, your fallopian tubes, every part of your reproductive tract is susceptible to some kind of cancer. Your breast, not to talk about every other organ in your body, your liver, your pancreas, all of these things are just literally, and it's harder. I recently lost a friend, a really dear friend, to cancer because it's one of those cancers that can also not be detected early stage. And by the time the person was diagnosed, it was too late, right? Okay, so with all that grim news, what is my role in ovarian cancer treatment? What I do is I study the microbiome. So the microbiome is the sum of all the microbes and their genomic elements. And don't worry too much about this. In any environment that you find microbes, right? So you can think, I think a lot of people think about microbes as germs, is what we used to call them, because you think about those little bugs that make you sick. But the microbiome is actually bigger than that. It's more important that it plays a lot of role, right? Most of the time they are helpful. They live with you. And at this point, people even consider them another organ of the body because they protect you, they provide, they help you in digestion and a lot of other things, right? So these microbiome or these microbes have been shown to be associated with a lot of things. People have studied them in looking at so many different things. And a lot of things also affect the microbiome. You can think about what you eat. So your diet can influence what your microbiome is like, the drugs you take, where you live, your genetics, your race or ethnicity, whether or not you're pregnant if you're a woman, and how much you exercise, and of course, whether you are sick or healthy, right? So these are all different things that can influence the microbiome. But like I said, the microbiome also affects our health in really significant ways. So people have studied the role of the microbiome, like I talked about, in things like preterm birth, obesity, how we metabolize the drugs we take, and of course in diseases. And the one that we're interested in is cancers, right? So when you had the cervical cancer talk, you heard all about human papillomavirus. This is one of the things you consider a microbe, right? It's part of the microbiome. And you heard the importance of how detecting that specific virus in your body, especially the 16 and the 18, can help the doctors and oncologists know whether you have cervical cancer or not using pap smear. And there's been a lot of other microbes that have been associated with different cancers, like Porphyromonas somre, which you do not have to remember, has been associated with things like endometrial cancer, Helicobacter pylori, gastric cancer, or Fusobacterium. So all these weird names are names of microbes that people have isolated or detected and have correlations with different kinds of cancer. So my job, like we already said, ovarian cancer is fatal mostly because it's diagnosed at a really advanced stage. It's dubbed as a silent killer because it would be with you, you have no idea until it's too late. So the most important, we don't have any screening tests as it stands right now. So my aim, or what I'm interested in trying to understand or to do, is try to find microbes, just like we do with cervical cancer with the HPV. Is there any microbe that we can be on the lookout for? That if we compare someone who doesn't have ovarian cancer to someone who has ovarian cancer, would we be able to identify a specific microbe that if we find this in patients or people, then we know that, okay, this is a marker for ovarian cancer, but possible presence of ovarian cancer. And then also how the disease progresses, can we be able to predict that if you have the specific microbes, you're going to progress quickly, move from stage 1 to stage 2, stage 3, like that, right? And also even how do you respond to treatment? When I read the woman's story, you heard how now, even though she's undergone surgery and even chemotherapy, but all of a sudden her cancer came back because the cancer has become resistant to the treatment that she's been going through. Sometimes the microbes in your body make it impossible for certain drugs to work on you. So is that a thing with those cancers? There's specific microbes that if we have them in our body, we can undergo chemotherapy, but would not have any good result out of it. So these are the 3 main things I'm on the lookout for. Is there a way to use a microbe to detect ovarian cancer? Is there a way to be able to predict the progression of the disease, or even how patients would respond to treatment? So that is the role of the microbiome that I am interested in ovarian cancer, which I don't want to bore you with because it's a bit too technical. But that's about ovarian cancer. And so if you have any questions, I can answer them, but I wanted to just quick key points is that ovarian cancer mostly affects postmenopausal or perimenopausal women who've never had children, or they had children late, had early menarche, or they started menses early, they had delayed menopause, or they have obviously specific gene mutations like the BRCA1 and 2 genes. And we talked about how symptoms are very non-specific. And especially even in early stages, you don't see much of anything. In late stage, you see these non-specific symptoms. There is no screening as it stands right now, but if you're suspected of cancer, you can do ultrasonography first. It can be followed by a CT scan, an MRI, or you can check for those specific tumor markers like CA125. And then you can have different kinds of surgeries like hysterectomy or laparotomy or laparoscopy for treatment, and of course followed by chemotherapy. But the most important thing is that you are aware of what ovarian cancer symptoms, as vague as they are, as non-specific as they are. If you start feeling weird, all of a sudden you're bloated all the time, you feel like your stomach has become full. You eat a little bit, like 2 spoons of some food, and you feel completely full. You have pelvic pain all the time. You have nausea and all these things that you know are not normal. You have to listen to your body, and you have to act quickly, because that's the only way, as it stands right now, to be able to prevent complications and hopefully increase your chance of survival long term. And with that, I would take any more questions you have. Thank you for your attention.
Thank you so much, Dr. Abby. Thank you. That was a wonderful presentation there. So if you joined us quite late, this is Dr. Abby. She is a postdoctoral research fellow, and the topic she discussed with us today is microbiome and how, you know, they are related to ovarian cancer. That was what we did today. I think I saw Say Lowe's hand up. I don't know if you still would want to put your question or your submission across. You can do that now. Somebody has written something in the chat section. Doc, I don't know if you would want to read it by yourself or.
Yeah, I can.
Right. Okay.
Faith, you mentioned H. pylori. That is it mean also patients are predisposed to ovarian cancer? Oh, so when I mentioned H. pylori, that was in association with gastric cancer. So H. pylori at this point is not associated with ovarian cancer. So no, that was just me giving examples of how people have used the microbiome, or by looking for specific microbes, where you're able to associate specific microbes with specific cancers, right? So the goal, or the gold standard right now, is HPV, which we all know is what doctors check for when you get a pap smear, right? So the gold standard, that's like really the gold standard right now. The goal is to be able to identify microbes for different cancers, to see if that will be able to help us to detect ovarian cancer or other cancers early. So yeah, so H. pylori is not associated with ovarian cancer as of yet. It could be, but right now, no.
Okay, so Saylo can now put across the submission.
Okay, Doc, that's a great presentation.
Thank you.
And in fact, I think you have answered the question from the point of view of your research.
I think you muted yourself.
Oh, sorry. Okay, I said that's great presentation, Doc. I am even low. Yes, I know.
Okay.
I know, that's a great presentation, and I think you answered my question. I wanted to know the rate of progress from stage 1 to 4, but I think that is what you say your interest is on your research. So I wanted to know how long it can take from the very first stage to the end.
Right, that is a great question, because the truth is, I talked about when I even talked about histology of the cancer. So one of them that I don't think I mentioned was mixed histology, which is basically just a combination. But the problem with ovarian cancer is that, first of all, we have very low number of patients that are diagnosed at early stage, right? And there are no studies really that show how it progresses, whether you move just from stage 1 to 2. Most patients, like even my data set, when I'm looking at the patients that I have in my cohort, I'm looking at it, I'm like, how many of these patients are even in stage 1 or 2? Most of them are stage 3 and 4. So it's already late stage. So it's really hard to be able to tell how it progresses quickly. So that's one of the things that we are trying to even understand using the microbiome. Can you specifically identify microbes that can tell you what stage the person is, and potentially if and how long they will be able to move, it would take for them to move from one stage to the other. But you see, the prognosis is also really, it's just ovarian cancer is really depressing, honestly, and so just scary, because one, when the prognosis is very bad, that people even at stage 1 is the earliest and has the best kind of prognosis, where you are able to get the 5-year survival rate to about 80 and 95%. But anything than that, then just the chances just go down drastically. So short answer, there is not a lot of studies out there, or really right now, no studies out there that actually outlines how long it takes for you to move from one stage to the other. Mostly because you don't have a lot of patients being diagnosed early enough for us to even be able to have this longitudinal kind of study to see how long they stay from stage 1 and progress to stage 4.
Yeah.
Thank you very much, Doc. There's a recommendation here. Good job, Doc. Very thorough and easy to follow and also understand. And that is coming from Mrs. Kate Darko. Thank you. Thank you, Mommy, for joining us today. So all too soon we have come to the end of today's episode of the CS Show. It's been wonderful weeks. You see, if you join in, you can definitely tell me that you are benefiting from this program, a proud initiative by Prophetess Rhoda Anna. And so don't come here alone. Invite somebody to come and also benefit from what you are benefiting from. It is about time we create the awareness there. We cannot afford to be losing our lives through these cancers and health issues. Okay, so before we come to the close to today's meeting, there is a hand up. Say hello.
Yeah, please share the link. So Doc can share the link, so we can share the link to those who haven't been able to participate. I'm sure they will listen later.
Okay, we will definitely do that. Thank you so much.
So Doc, please share the link with us. Thank you.
I think Rhoda usually does a Facebook Live, right? So the link, it's usually on her page. So what's the best way to share this?
Okay, so then I could also just simply type the Zoom ID. You just type it and it will bring you straight away. So I would do that straight up.
But this would be for the Zoom, it has to be a live, like you can, this would be.
Okay, so once you come on, it is live on Facebook. We are live on Facebook right now. So yes, you can go to.
So what is that link on Facebook?
Right, that's what, so Rhoda, are you able to share that? I don't know the best way to share that right now. I know Rhoda's page usually, is there another way? Is there any, because I know you.
So you go and like Manifestation of Holiness on Facebook,
No,
and then
I know Rhoda's page usually. Is there another way? Is there any, because I know you.
So you go and like Manifestation.
Okay. Wait.
Okay, so what has been shared right now is the Zoom account. The Zoom account has been shared, but you just simply go to Facebook, search for Manifestation of Holiness. You like the page, and then you are good to go.
Thank you.
So this page should have like talks from before, right? The CS program from weeks before, because I think I've
yes,
seen that.
Definitely. You can also go to our website on Manifestation of Holiness, blog.com, to also get all that we have done from the previous weeks. Yeah, so you go to our website, www.com, manifestation of holiness blog.com. You will get it there. Right. So I want to say a very big thank you to Prophetess Rhoda Anna. Okay, so the Facebook link has been shared, and also the website has also been shared in the chat section. Thank you so much, listener, for doing that. So I want to say a very big thank you to Prophetess Rhoda Anna for this initiative. It is a wonderful one by all standards. And also say thank you to Dr. Abigail Asangba. That was a wonderful presentation there. We definitely would want to have you back on the CS show. Yes, and I cannot leave without saying thank you to my audience. Without you, the CS show wouldn't have been possible. You are the reason we are doing this. You have always been amazing, but all that I'm asking of you is to keep inviting friends to come and, benefit from what you are benefiting. My name is Paulina Amankwa. You can call me Lina, better still, Ajua Kasabo. I am the host for the CS show. So Manifestation of Holiness, like I said earlier, we meet here from Mondays through to Fridays for our morning raw, 12 a.m. US time, 4 a.m. Ghana time, 5 a.m. UK time, 6 a.m. Europe time, 7 a.m. Lebanon time, and 1 p.m. Japan time. We also meet for our Zion hour, Mondays, Thursdays, and Fridays. The time is 12 p.m. US time, 4 p.m. Ghana time, 5 p.m. UK time, 6 p.m. Europe time, 7 p.m. Lebanon time, and 1 a.m. Japan time. You have been wonderful. You have been amazing. Take very good care of yourselves. Stay safe and stay blessed. It is bye for now. Bye-bye.
Bye.
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 Bye. Thank you.